All right, so we're going to get started. Welcome to this webinar, everybody. Paying for PrEP, what the new CMS rule means for you. And I'm super excited to have two experts from representing federal government to explain to us the specifics of the new ruling and how it impacts patients and people using PrEP, and also for PrEP navigators or folks who are doing that work in community-based organizations to know what to do when they talk to potential PrEP patients or people who are interested in PrEP about how to pay for PrEP, because in my work around the country, talking to even now 9 years, almost 10 years into the introduction of PrEP as a prevention strategy, a lot of times folks in communities are still have a question about, well, how do I pay for it, right, if I want to get it? And so the new ruling is a really exciting development for patients. We want to make sure that people are aware of this rule and what it means. My name is Kenyon Farrow. I am the Managing Director of Advocacy and Organizing with PrEP for All. PrEP for All was founded in 2018 as an organization of community members, healthcare professionals, lawyers, and academics, all dedicated to increasing access to life-saving HIV medication. And I think folks know that in the last year, like many of us who are working in HIV have also lent our time and efforts to COVID-19. And so we've also been doing work around coming up with strategies to advocate for more global production and access to COVID-19 vaccines as well. So we have two speakers today who will be presenting their work on the new PrEP ruling, kind of what it means for us today. And our first speaker will be Jeff Wu. Jeff Wu is the Deputy Director of Policy for the Center for Consumer Information and Insurance Oversight, which operates healthcare.gov. He leads the center's work promulgating policy and regulations for the Affordable Care Act's health insurance reforms, including the health insurance exchanges, and the center's work with the Departments of Labor and Treasury regulating group health plan coverage. Before joining the Center for Consumer Information and Insurance Oversight, Jeff was an associate with the law firm of Covington and Burling. Prior to that, he was the associate with the financial institution strategy practice at Oliver Wyman and Company, and a public school teacher on a Native reservation in Northern Canada. He's a former law clerk to John T. Noonan of the Ninth Circuit of the Court of Appeals and Justice Jack Major of the Supreme Court of Canada. He has a JD from Stanford Law School and an MBA from the Stanford Business School and an AB in economics from Harvard College. So I will turn it over to Jeff, and you can share your screen now. Thank you.
Kenyon, thanks so much. Thanks. I don't have any slides to share. I'm going to basically talk. I want to thank you, the work of the coalition, all the folks on this call for your work on the matters that we're going to be talking about, which are obviously critically important and to which you've dedicated such a substantial part of your career, but also the work that you've been doing around advocating for COVID-19 vaccines, which is obviously such critical work these days. I think we've all found that our work has been massively changed and shifted over the last number of years for that work, as mine has as well. I thought what I would do is kind of do a walkthrough of the guidance that we put out recently, really focusing on sort of what the statutory basis for it is and what the guidance says. And then I thought I would talk a little bit about the suite of services that are covered under the guidance, which I suspect will be of real interest to all the folks on this call. Talk a little bit about medical management and what the rules are around that. I imagine that comes up quite often in your sort of advocacy work and community work, and then talk about enforcement. And then after Cedric speaks, of course, I'm also very, very happy to take questions on this stuff. So sort of to start with, So this is guidance that applies to essentially to commercial insurance. It applies to all group health plans, which cover a very, very large chunk of folks in American society. It covers folks in ACA compliant individual market plans, and so together that is a broad bucket of what we think of as commercial plans. It doesn't cover plans that are not regulated by the Affordable Care Act, plans like the short-term limited duration coverage and the like. So there are it's a pretty small segment of the market, but there are sort of alternative plans out there that are not covered by the full scope of the Affordable Care Act and the Public Health Service Act protections. But for the vast majority of plans that are covered, plans we consider sort of major medical plans, the rules around those plans are written by the departments of the Treasury, Labor, and Health and Human Services together. We call them the tri-departments, and we issue sort of rules and guidance around all of these provisions to make sure that there are parallel rules being applied to ERISA plans, right? That the Department of Labor has jurisdiction over. So if you work for a large firm, large company that has a self-insured plan, those are ERISA plans, and those are governed by these rules. The Department of the Treasury enforces a lot of the penalties around this stuff through the Internal Revenue Code. A lot of these rules are tax rules. And HHS brings to bear a lot of the substantive healthcare expertise. We also govern through the Public Health Service Act, have a strong hand in governing individual market, small group, so small company insurance, as well as non-federal governmental health plans. These are plans. So if you work for, say, a city Department of Health, you might be covered by group health coverage that doesn't technically fall under ERISA. It falls under HHS coverage. ERISA, yes. So, oh boy, now I'm really being put to the test here. I will just describe ERISA as the statute that governs health plans that are provided by your employer. It covers also retirement plans. It's the Employer Retirement and Income Security Act or something like that. It also covers retirement plans, but for our purposes, it covers group health plans. So the Affordable Care Act had a statutory provision that amended the Public Health Service Act. And the gravamen of that provision is that it requires insurance companies to provide certain benefits around preventive services and prohibits cost sharing associated with those services. The services that are covered are evidence-based items or services that have an A or B rating from the United States Preventive Services Task Force. Or they're immunizations used routinely with children, adolescents, and adults that have an ACIP recommendation. ACIP is an advisory committee under the CDC. They are much in the news these days because they are the ones that have been providing the recommendations around the COVID vaccines. So these two pathways to getting on the list of preventive services for which that must be covered by these plans and have to be covered without cost sharing. So that's no deductibles, no copays, no co-insurance, and so the guidance that we have recently put out specified sort of how that works with respect to PrEP. So back in June, so early June, back 2 years ago, on June 11th of 2019, the U.S. Preventive Services Task Force, so one of the two channels that feeds into this list of preventive services, did release a recommendation. They gave an A rating with respect to PrEP, or effective antiretroviral therapy to persons who are at high risk of HIV. And so that recommendation triggers the statutory provision and requires coverage from all of these plans and requires coverage without cost sharing. So therefore, plans and insurers have to cover PrEP. consistent with the USPSTF recommendation. No cost sharing, and it kicks in for plan years. So if you are in many markets, plan year starts around January 1st. But as folks may know, if you are on your company's health plan, sometimes the plan year starts like in July or something, right? But plan years beginning on or after a year following the date of the recommendation. So the three departments heard from many of you all and from lots of stakeholders that plans and insurance companies were interpreting this recommendation quite narrowly. So they're really only focusing on sort of this top line message around the recommendation of the antiretroviral therapy itself, and not the full set of recommendations, which cover a fuller suite of services that go along with PrEP. But if you dig deeper into the recommendation from the USPSTF with respect to PrEP, the recommendation covers and cites CDC guidelines, and those guidelines say that PrEP is part of a comprehensive intervention. It's not just the medication, but it includes essential support services, medication, self-management, adherence counseling, risk reduction strategies, mental health counseling, and all these, of course, are intended to make sure that PrEP is administered safely and effectively to the people who need it. And so, consistent with the CDC analysis, the recommendation from the USPSTF, and this is the recommendation that is binding on insurance plans, includes, along with the therapy itself, a combination of baseline and monitoring services. So it includes certain clinical assessments that are necessary to ensure that the medication is prescribed to at-risk persons who are not infected with HIV and have no medical contraindications. To require monitoring to ensure sort of safe, ongoing use. It also encompasses a baseline and monitoring services. So it requires sort of HIV testing, hepatitis B and C testing, testing of creatinine, and a number of other tests that would kick into place. Pregnancy testing, screening for sexually transmitted infections, and I mentioned before, I think adherence counseling and the like. So because all of these are covered by the recommendations, they're all part of the set of services that go along with PrEP. And so therefore, again, are all required to be covered by the plan without cost sharing to the individual. And of course, it's super important that an individual have access not just to the medication itself, but to all of this suite of services that go along with it to make sure that the medication is being taken appropriately and safely. In addition, plans and issuers have to, and I've been using this phrase, it's sort of a term of art, plans and issuers, because plans cover employer plans, right? Like self-insured plans. They're not necessarily insurance companies themselves, even if the insurance company helps administer. But in any event, your insurance company, your plan, is also required to cover, with no cost sharing, the office visits that are associated with each of these services that are applicable when the service is for the primary purpose of the delivery of these services and aren't sort of tracked separately for some other purpose. So the suite of services that are covered here is not just the medication, but a much broader suite. It's the full set of services that are necessary to the effective administration of the medication. An issue that comes up a lot is and the guidance addressed all of these topics, right? An issue that comes up a lot is medical management. It's long-standing guidance from the three departments that that reasonable medical management is permitted with respect to preventive services. But the way our rules work is if the recommendation specifies certain things, then that is required to be covered, and you can't sort of medically manage around that. But if the recommendation is sort of silent on something, then a plan or issuer is allowed to employ reasonable medical management techniques. So For example, when PrEP is medically appropriate for an individual under the USPSTF recommendations, as determined by that individual's healthcare provider, it's not reasonable to restrict the number of times the individual can start a course of PrEP. That can't be something that's blocked by medical management. On the other hand, since the recommendation does not specify that that the branded version of PrEP must be prescribed, plans and insurers can choose to cover a generic version of the PrEP medication without cost sharing, and they can impose cost sharing on the brand version. However, there has to be some process for accommodating an individual for whom the generic version isn't medically appropriate. And all this is as determined by the individual's doctor, their healthcare provider. So there has to be a mechanism to sort of seek an exception to that. And whenever a plan or an insurer is using these medical management techniques, there has to be we have said there has to be an easily accessible, transparent, reasonably expedient process for seeking an exception and getting an exception. So that's medical management. Third topic I wanted to cover quickly is enforcement. So the way enforcement works on this guidance, as with all preventive services, is a combination enforcement scheme between the federal government, 3 departments that we cover, and the state governments. Most states are sort of the first line of enforcement for preventive service requirements. What does that mean? That means if a plan, for example, let's say an insurance company in a particular state, is adopting an interpretation of what they have to cover here that is contrary to what I went over, then the state is sort of first up to go to that plan and make them do what they are required to do under the law. If someone were to come to the federal government in most of these states, our first step would be to work collaboratively with the state, contact the state, make sure that they were following up on these things, because they're stepping right sort of in the first instance. There's a small number of states for which that have disclaimed enforcement authority over some of these topics, and so we enforce directly. And if a state is not substantially enforcing, then the federal government can step in. The reality is that we do this very much in a collaborative fashion with the states. We absolutely invite you all, other folks who see instances of non-compliance, to either come to the state or come to us, and we're happy to sort of take the ball from there and work with the states and work through that process. We don't expect non-specialists in these areas to know exactly which department to go after, and it's not the intent here to sort of make people chase through different layers of the bureaucracy. As soon as we are aware of something, then we will work with the states to make sure that compliance is enforced. The FAQ, the guidance document that I'm talking about, did make allowance for the fact that the plans and insurers may not have understood the full scope of services that were required to be covered in this case. And so we did say that that we expected them to come into compliance quickly, but that in the meantime, we gave them sort of 60 days from the issuance of this guide to sort of come into full compliance, which is like now, right? So now the full sort of enforcement and compliance regime is in place. So I've probably taken much longer than I certainly expected to. So in going over that, maybe far too much detail for folks, but happy to answer questions once Cedric has had a chance. Thank you.
Thank you, Jeff. So the question that's in the Q&A box for you, when you say the state is the first line of defense, is that the State Department of Health or something more legal, or another sort of state agency that people should be paying attention to for payer non-compliance with the rules?
So it's a good question. It's always a little bit tricky because every state is a little bit different, but typically it's actually the State Department of Insurance. It's the folks who regulate the insurance companies, because these are rules that apply to insurance companies. Of course, if it's a self-insured plan, I mean, for folks who are into the weeds on this stuff, if it's an ERISA plan, states are preempted from doing anything, and that just goes straight up to the federal government, to the Department of Labor, and to us. But yes, it would typically be the Department of Insurance. Sometimes that's sort of under the Department of Commerce or whatever, but it's the folks who regulate the insurance.
Great. So two more questions that came in. So what else, in addition to restricting the number of times an individual might start a course of PrEP, would fall under the category of medical management in this case?
So yeah, the main issues around medical management that come into play that we see are often sort of this generic brand question that I mentioned. Sometimes with many preventive services, there are a number of products in the market, and it is okay if the recommendation hasn't specified for a plan to sort of apply, say, step therapy. So you have to start with this one before you go into those ones and the like. That's not really applicable in this case. There's the generic brand issue but I don't think there's a lot of other substitutions here. So I think the ones that I covered are the main ones, certainly that we have heard of. But like there's no end to the creativity of folks in our society. So I certainly would not be surprised if other fact patterns were to come up. I'm not aware of others, but we'd be happy to look at issues that came up.
Great. And last question also came in the chat box, which was also a question I was going to ask. What is the mechanism for registering complaints regarding non-compliance? So how does a patient or a PrEP navigator initiate that enforcement process?
Right. So that is interesting. So I can't speak for the states. I think most states have, if you go to the website, have a process for lodging complaints or issues with respect to insurance companies. So again, this is like the Department of Insurance, or sometimes called the Department of Commerce in a state, and that would be the process for them. With respect to us, we tend to, our call centers and the like tend to deal directly with issues around like healthcare.gov or Medicare and the like, and they're probably not the best channels to sort of bring these to our attention. I think that the best channels sort of at this point, we are sort of in the process of standing up a sort of a complaints website and the like. It is not up yet and won't be up for some number of months. In the meantime, coming to me, coming through PrEP for All and advocates like that, they know how to get in touch with us, and we're in close contact with those folks and happy to look at stuff that way.
Thank you. So I see more questions coming in the chat and the Q&A function. So we'll come back to some of those. So I'm gonna but pause on the questions, and some may be answered by our next presenter. And if not, we will open back up to the Q&A for the second portion. So introducing our next presenter, Cedric Pulliam is the Senior Advisor to the Chief Medical Officer of the Department of Health and Human Services, Office of Infectious Disease and HIV/AIDS Policy. This office, which is part of the Office of the Assistant Secretary for Health, coordinates the Ending the HIV Epidemic Plan for America initiative and the development of and implementation of our national strategic plans for HIV, viral hepatitis, sexually transmitted infections, vaccines, and vector-borne diseases. Cedric advises and provides subject matter expert support across the broad infectious disease portfolio of the office. Previously, Cedric served as Senior Project Officer at the CDC in the National Center for HIV/AIDS, viral hepatitis, TB, and STD prevention in the Division of HIV/AIDS prevention. The prevention program branch, where he managed CDC HIV prevention grants to health departments and community-based organizations. Additionally, he provided expertise on testing diagnostics, EHE Diagnose, the EHE Diagnose Pillar Work Group, telehealth and teleprep, LGBT health, health equity, and public health and homelessness. He served for 4 years previously in the Global HIV Department at the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR, at the U.S. Department of State, working in multilateral operations, human rights, gender, key populations, stigma and discrimination, and community civil society. Cedric?
Thank you so much, Kenyon. Let's go ahead and get those slides up. And good afternoon, everybody. Thank you so much for joining us. Definitely looking forward to answering some of the questions that I think I will cover in my presentation as I go through kind of the state of PrEP from the public programs or federally funded public programs perspectives. All right, thank you so much. You can, yes. All right, so already been introduced, so next slide, please. So I will cover basically the federally funded public programs and looking at PrEP in that sense. So first I'll just discuss Medicaid and Medicare. Then I'll look at some of the funded healthcare. So Indian Health Services or IHS, public health and clinics from the perspectives of the CDC, HRSA, as well as some of our other HHS agencies that are implementing funding for these healthcare facilities, the Department of Veteran Affairs, our National Ready Set PrEP program, and some key takeaways. Next slide, please. So to start off with PrEP coverage for Medicaid, looking at traditional Medicaid, there are several different factors that I want to provide you all on this particular platform. You looked at risk-based HIV screening, it is covered. Routine HIV screening is optional. For 43 states, it is covered, and other states, they are not covered. PrEP medication is covered, but this may have a prior authorization off of the state determination. And I'll go into that a little bit more in detail as we continue this discussion. STI screening and adult immunizations are also optional. And the U.S. Prevention Services Task Force Grade A and B recommended services are covered without copay. And then in there, as an addendum, the optional but incentivized with a 1% increase in federal match. So for Medicaid, this does cover as for routine HIV screening and for PrEP medication. This does showcase that, you know, it depends on your Medicaid expansion status for one. And then it depends on what your state has elected and has not elected for specific services to be covered under this particular aspect when looking at PrEP coverage and PrEP navigation services for Medicaid. There are more detailed areas when it comes to Medicaid that are specifics that may not necessarily be covered in regards to PrEP, but also just routine, the check-ins that are required for lab visits and testing to continue PrEP medication throughout that coverage area. But again, these are kind of the general rulings for the Medicaid component when looking at PrEP. So Medicaid expansion. So these are very specific points that kind of goes into effect for a user that is in a state and residing in a state and seeking PrEP navigation in a state with Medicaid expansion. So the first point here is showcasing that HIV risk-based testing and routine HIV screening is covered. So the user should not be being charged or should not have to worry about any costs related to these, to any risk-based or routine HIV screening or testing in a state with Medicaid expansion. PrEP, STI screening, and adult immunizations are all covered as well. And for the USPSTF grade A and B recommended services, it includes PrEP medication and associated services are covered without any copay at all. Next slide, please, Kenyon. Continuing on, all ARTs required to be on Medicare Part D plan formularies and available without prior authorization. So this is very important looking at RTs, and this is specific to Part D plan formularies. So I just wanted to highlight that. Additionally, when looking at Part D of Medicare regarding PrEP medication, this is subject to cost sharing. And so this is a very important piece to really think about for those clients that are under, or if you are yourself under Medicare Part D, that PrEP cost sharing can range from $1,000 to $2,000 annually, so per year. The sliding scale copays available for low-income Medicare beneficiaries also are available for under Part D. And there's a change to no cost sharing required by a national coverage determination. And I am not necessarily from CMS and the expert in this particular space, but I will say questions that are specific to Medicare, specific to D or any other areas or formularies, I will say to definitely get in touch with me post this webinar to be able to answer your question thoroughly and accurately. And I will definitely respond to your emails, and I'll provide my email at the end of the slide deck. So prevention services with the USPSTF grade A or B recommended grade rating provided under Part B of Medicare, such as routine HIV and STI screening, are covered without any cost sharing. The PrEP lab tests are subject to cost sharing. Cabotegravir for PrEP would be a Medicare Part B service. Next slide, please, Kenyon. So this is a particular update, and so I'll go by agency. And this is from HRSA, from the Bureau of Primary Healthcare. So overall, health centers reported the following in calendar year 2020. They covered around nearly 2.5 million HIV tests that were conducted in calendar year 2020. Over 389,000 PrEP patients were seen and provided PrEP Navigator services at over 925 health centers. And of these PrEP patients, 151,000 or 40% through 195 health centers received fiscal year 2020 primary care HIV prevention funding. 81% of patients, or 6,304, with first HIV diagnosis were linked to care within the 30-day time frame. And 190,000 patients with HIV received primary care services at health centers, including many sites co-funded by Ryan White. So a little bit about the primary care HIV prevention, or PCHP funding. The sole purpose in prevention and treatment services of people at risk for HIV transmission, including those who are living with HIV. Continuing on to the Indian Health Services, looking at tribal and urban Indian clinics. So far, some of their data showcases that there's been a total coverage of 57.2% of HIV, an increase of approximately 20,000 patients screened between 2016 to 2019. So there's been an uptake of increase of HIV screening. And about 50% of that was coverage within men the age of 25 to 45. Next slide, please. And when looking at the Indian Health Services PrEP ECHO program, this program was created to help increase an uptake of PrEP with Indian Health Services in tribal and urban Indian clinics throughout the nation. And as you can see over time with the ECHO project, you saw an increase, a gradual increase of more PrEP uptake, or patients or clients being navigated to PrEP services. And now in many of the sites throughout the nation, you are seeing at least over a 25% increase of more than 10 clients per that is seeking PrEP navigation services and continual PrEP coverage over time. Next slide, please. Going into the CDC and specifically STD clinics, when looking at the ending the HIV epidemic priority areas, there's two parts of CDC funding that is providing funding specifically to this. That's S20, specifically component C of PS 2010, running from August 1st of last year through July 31st of 25. And then PS 2004 is the National Network of STD Clinical Prevention Training Centers, and continuous funding over a 3-year period for an uptake of STD clinical visits, screenings, and PrEP coverage as well. Next slide. So one of the here is that STD clinics are well positioned to support PrEP uptake, and main areas for component C of the EHE funding that CDC provides is really making sure that that is a focus, that STD clinics can be a pillar to increasing PrEP uptake for clients in their jurisdiction. So 30 of the 31 clinics conduct PrEP assessments and referrals. 25 of the 31, and these are 31 that are funded through component C of PS 2010. 25 of the 31 have lab capacity needed for PrEP labs, and they also 31 offer PrEP by prescription, and 15 of the 31 offer PrEP starter packs on site to clients. Additional PrEP-related progress is that they've started looking at establishing teleprep as an option for people who take PrEP, implementing nurse-driven PrEP protocols, and QI work to improve PrEP initiation and retention. Challenges that we're still seeing is PrEP retention and teleprep because they're evolving modalities of PrEP navigation services. And so some sites are doing great, some sites are having challenges and trying to navigate around those challenges. Next slide, please. So the Department of Veteran Affairs has an amazing Sti Co-Testing Dashboard that includes PrEP, HIV, and Hep C, all dashboards that are like real-time data across the nation for the veterans that are being served under VA. So pharmacists develop these dashboards, which basically lists patients needing action. So things that they need to get completed in order for a patient to be, served and provided the care that is needed for them. Looking specifically at PrEP dashboard, this particular dashboard identifies veterans with multiple risk factors for HIV, showcasing PrEP candidates and identifying PrEP patients who are late for refills or clinical visits or labs or testing. Next slide, please. So the Office of Infectious Disease and HIV/AIDS Policy manages the Ready Set PrEP program. That is a national program that is linked with supporting and cooperating pharmacies to ensure that PrEP is provided to clients throughout the nation. So 32,000 pharmacies are a part of this co-sponsorship agreement. There's been considerations of expanding to other pharmacies, including health centers and Indian health services pharmacies throughout the nation. There's also been expansion of Ready Set PrEP mail order via the trial card and other pharmacies. We've established an EHE pharmacy task force under the Public Health Service Commission Corps. And this kind of assists with force multipliers for pharmacy engagements because we want to meet them in multiple touch points throughout the nation. And OIDP partners with pharmacies to educate communities on PrEP to ensure that they understand the value add for PrEP and the prevention toolkit for clients. Next slide. And some of the basic key takeaways from our public programs that are federally funded, PrEP access is expanding, but policy, program, and cost barriers remain. Pharmacists and nurse-led programs and teleprep programs can facilitate increased access to PrEP. We are really poised to have better data to monitor PrEP access and utilization nationwide, and also possibly disparities or inequities that exist in PrEP navigation and access. The further expansion of the reporting and monitoring of data is highly needed throughout the nation and throughout jurisdictions. We have a concern that changes to patient assistance programs or 340B drug pricing programs and new generics coming in January of 2022 could possibly impact access to associated PrEP services, and considerations are underway on approaches to increase participation in our Ready Set PrEP program. Next slide. I want to thank all of my federal colleagues who helped with this particular presentation. Next slide. And that is my email. If anyone needs to contact me directly for additional questions that may not be covered under the webinar, and I will revert it back to you, Kenyon, for a Q&A. Thank you.
Great, thank you. Wow, so we have lots more questions. I'm going to try to do these as quickly as possible so we get them all in before the hour. First question, does the provider or health plan determine whether PrEP is medically appropriate for a patient?
Provider.
Provider.
Okay, great. Thank you. Is there an enforcement issue when insurance is brought across state lines? So in this example, our state, Texas, marks which insurances are watched by our system. So I'm confused on whether they would enforce with different state plans.
So there's a number of pieces to this. So some plans are sort of inherently across state lines because they're like self-insured. For example, like the Department of Labor would sort of cover those. So those are federally enforced, and so there's no real issue. Now imagine you get a Blue Cross plan, say in Texas, like HCSC, right? And let's say you go across state lines and you get you're seeing a provider in Oklahoma. I mean, Blues plans have very broad nationwide networks. That's sort of one of their value propositions. And so this would be a totally normal, reasonable thing to do. If there were an enforcement issue on the insurance company, so for example, let's say the insurance company did not comply with sort of the provisions that I outlined at the beginning here, or like they refused to pay for some of the related services or whatever. Yeah, the Texas Commission. Texas is sort of a special case because Texas is I think one of the states where the federal government enforces. But let's say we're Florida, and you cross state lines to Louisiana or something and saw a provider in Louisiana. Yes, then the Florida Department of Insurance could absolutely take action against a Florida-based insurance company because they weren't complying with the rules, even if the provider is across state line.
Thank you. And I can't remember if either one of you covered this, but does the new CMS rule apply to insurance plans in the U.S. territories, including Puerto Rico, or specifically Puerto Rico?
That's a question.
And the person also asked about Medicaid in the territories, like Puerto Rico.
That's a very good question.
That's a very good question. And things always get a little bit complicated with territories, particularly around Medicaid issues. I will say Medicaid's a very big deal in the territories. A very large portion of the population is covered by Medicaid. These rules do apply in the territories, I believe. What gets tricky in the territories is there aren't exchanges in the territories, right? So like a lot of the rules that we administer don't apply in the territories because there are no exchanges and the like, and there's certain other provisions that don't apply tax credits and the like because of that. But here, if you are in, say, a group health plan, in Puerto Rico, yeah, they have to comply with all of the Public Health Service Act requirements, and so that should apply. I am almost certain of this, but I want to check. And if my answer is different, Kenyon, I will get back to you to circulate a corrected answer.
Okay, I appreciate that. So,
and let me just back onto that. On the Medicaid website for Puerto Rico specifically, it does differ. Puerto Rico has a kind of different structure and some of the territories when it comes to Medicaid. And so the federal government, like in particular, when looking at matching, some of it will be matched based off of the different formularies, the plan formularies, and also what part of Medicaid is being discussed or focused on for a particular healthcare issue. So there are differences, and I'm happy again to be linked with the person who asked that question in regards to Puerto Rico and the other territories. Thank you.
Thank you. And this question, I also hear a lot in community. As we're now developing new PrEP modalities, and I think, Cedric, you mentioned cabotegravir, which we know may be approved this year by the FDA, the long-acting injectable. How do we think these are going to shake out in terms of the U.S. Preventive Services Task Force ruling, and also CMS in terms of how newer modalities of PrEP will be covered or not covered under the rule?
So just to jump in quickly. So as new products or services are approved by the FDA, again, it goes through one of those two committees. In this case, it would be the USPSTF, U.S. Preventive Services Task Force. If the task force were to make the recommendation, make the A or B recommendation in those cases, and those are very evidence-driven deliberations. But if they make that recommendation, then yes, the structure that I have talked about here, sort of the full set of services that are under the recommendation, reasonable medical management to the extent not countered by the recommendation, the enforcement process I talked about, all those would.
Okay, so with each new drug development, we'll go through the same process, essentially. Thank you.
Yep. There is that gap in application, so it doesn't happen sort of the day of approval, right? There's just sort of like we give the plans like a year, sort of come into compliance. They have to sort of often change their benefit structures and the like. They often don't even cover these products sort of right off the top, and so they have to sort of make those changes. Yes.
Thank you. So next question, which I recognize the name, so I know this is about my hometown, Cleveland, Ohio, is about, and it's a question I used to ask in New York when we were developing the state in the epidemic plan, which is, what happens to young people because of the ACA? People under the age of 26 are still under their parents, or can be under their parents' insurance plans. This person asked, their organization works with many youth who are interested in getting on PrEP. The challenge arises when they don't want to utilize their parents' insurance to pay for PrEP and the ongoing testing and certain, the services that show up on the explanation of benefits, right? So are there options, or is there, and this is probably a state by state issue, but is there a sort of federal, kind of thinking about how to deal with that conundrum?
I'm about to say that is a great question. This has been a topic of discussion or barrier from the very beginning, as you already mentioned, Kenyon. Only 12% of youth are getting PrEP coverage recently based off of 2019 data. So it's still a significant low amount of youth being covered. And this is probably one of the main barriers on side of looking at, insurance coverage, visits and testing and things that are routine for PrEP coverage. And so there's not necessarily a federal policy ruling or in regards to, how can that be navigated to PrEP without like utilizing parents or utilizing, different kind of non-barrier driven PrEP navigation services or different modalities. But a lot of the alternatives have been able to at least follow the guidelines regarding age and weight. That has been a part of the PrEP guidance and PrEP policies from the federal government's perspective. And some of the teleprep avenues have also been a gateway of success that we've seen from looking at PrEP coverage as well, looking at like the MR and other NERCs and other programs that exist for tele-PrEP navigation. And that's kind of what I want to touch base on there, because there's not necessarily a answer for it, but it is some options based off of, what the FDA approved guidance for PrEP and the weight, the national age and national weight kind of standards. And so that way it has kind of helped a little bit with the patient services and some of the other services that are based in each of the different state sections. Thank you.
You're welcome. Yeah, I just to say follow up on that. I've wondered if there's a way for young people they're adults, right? They're over 18, but it's on their parents' insurance. Can they roll? And in this case, this is Ohio, which is a Medicaid expansion state. Can you roll those young people onto Medicaid potentially through the expansion, if as a possibility? I'm just curious. But they don't. All right. So I saw the person in the chat box said they can't actually do that. That Medicaid, I guess, is the payer sort of last resort if there's another payer. So that's a policy loophole that we probably will have to address at some point. Thank you. So this question, this might be too down in the weeds, the question says. Nothing is too down in the weeds, I think, for this conversation, but I would like to hear any tips about ICD-10 coding. Best ways to make sure the suite of services is understood by the insurer to fall under these rules since we don't yet have a specific ICD-10 code for PrEP?
So this is way down the weeds, and congratulate the questioner who clearly sort of knows their stuff. So on this one, I think the problem here is that there's no, we don't have a federal rule or structure that says, one must code this way or that way, or these are the codes that must be accepted and the like. So I think a lot of this, could end up being a payer by payer sort of situation. Like certain payers will recognize the coding in this way versus that way. I don't have any particular advice on this other than systematically sort of, like learning from, working through these issues with particular payers might be very useful, just, and then circulating that information so folks know, hey, when you're dealing with, I don't know, Cigna, this is the way they need to see the coding. That might save everyone a lot of hassle.
Thanks. So another question, person says, I have patients who have insurance plans that assert they are not ACA plans, and the medications require explicit program exclusions. So are there provisions, and under what circumstances can an insurance plan not cover PrEP services?
Yeah, so there are a few types of commercial insurance that are not covered by the Public Health Service Act, sort of all of its provisions, or the Affordable Care Act. And so I put out as examples here, there's a kind of coverage called short-term limited duration insurance, which is a kind of insurance that you can purchase for short periods of time. That it doesn't have a lot of restrictions on that insurance, so they can absolutely carve out certain benefits. There are other kinds of coverage that are not technically insurance, but look a lot like insurance. So things like healthcare sharing ministry coverage. There are certain kinds of fixed indemnity plans and the like that are out there. They're not sort of what I consider sort of major medical coverage, but they don't cover a ton of people, but there are some people on these plans. They're more prevalent in certain areas than others. If it is one of these plans, then it is very plausible that they have excluded coverage of these benefits, and there's nothing the insurance regulator would be able to do that.
Next question is for Cedric. There was a comment. Do you have demographic data available on the PrEP clients you mentioned on the slide about the kind of health centers PrEP prescriptions for 2020? You mentioned 389,000 patients. If you have the demographic breakdown that folks ask for, to see that at some point if possible.
I don't have the demographic breakdown data from in front of me, but I can, because I think I know who asked that question. I can see if that data is available from my HRSA colleagues and get back to the person.
Great. And let's see, there's just a couple other ones. Do you have is there a link that folks can look at for the VA dashboard, or is that?
No, because that's EHR data. So that's within the VA system. Unfortunately, it's not a public, because it's a HIPAA compliant EHR data or electronic health record data that is included.
Great, thank you. And last question, is there a ceiling on the amount of copay a medical provider can require with regard to PrEP or PrEP services?
If those services fall within the strictures that I've said, sort of within the recommendation, there is a ceiling. The ceiling is zero, right? No co-insurance, no copays, no deductibles are permitted.
Thank you. Yeah, I wanted you to reiterate that. So if I'll just open it up again to our speakers, if there's any last minute thoughts or things that you want to share or leave our folks with before we adjourn.
This has been a really great and much needed conversation, and I'm really grateful that so many people took the time to join today. remember, we want to hear and to have these sort of discussions with community. So, and those that are providing services to community to ensure, not only equity and inclusion, but also this navigation to PrEP and access to PrEP is increasing across the nation, because coverage is quite low, and we recognize, see a difference. And so we appreciate PrEP for All. We appreciate you, Kenyon, having this very important conversation, and please feel free to reach out to me. I'm working really directly with the HIV team within my office on PrEP and other components. So thank you.
Thank you.
And similarly, I'd really like, Kenyon, I'd like to thank you, Cedric. I'd like to thank you for being onto this panel, and for everyone who participated. At CMS, I think we also agree this is a hugely important topic. If folks would like to get in touch with me or have further questions or the like, maybe Kenyon, are you a good sort of conduit to through?
Yes. So folks, I'll drop my email in the box. And so if you would like to get in touch with Cedric or Jeff, if you didn't get the emails, you can email me just at Kenyon at PrEP for All. I'm saying it and typing at the same time, .org. So that's up in the chat box. So reach out to me if you would like to reach Jeff. I think Steve Cedric put his email in the box too. So with that, thank you both so much for your wealth of information and time presenting for us today. And we will be doing this again soon. So if there's topics or conversations that you would like more sort of detailed conversations, education, whether from federal partners or other advocates, please also reach out to me too, because I would like to do more kind of ongoing series about some of these issues in terms of PrEP access across the country. Thank you all. Bye.